You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Well, welcome everyone. My name is Amy Attaway. I'm here with ATS Breathe Easy podcast. I'm one of your hosts. I'm back again with Dr. Anzueto, Antonio Anzueto. So we had a episode a couple weeks back about nebulizers and COPD. And given he's the expert on all things COPD, we thought it'd be great to have another conversation with him about controller medications in COPD. And just to give some background, so Dr. Anzueto, he's professor of medicine at University of Texas Health Science Center and the chief of pulmonary for the South Texas Veterans Healthcare System, and also on the GOLD Science Committee, and has helped organize the GOLD guidelines, many iterations. So I think we could start maybe in discussing like how we define controller medications in COPD versus short-acting agents.
Thank you, Amy. Thank you for the ATS for inviting me to participate in this activity. Certainly, one of the important issues is the difference between medications. Short-acting bronchodilators by history was the first medication that became available. Then we started getting the long-acting bronchodilators, and they became what we call now controllers because they not only are long-acting, you have to take it, most of them once a day or twice a day. Their efficacy results in sustained improvement in lung function, improves the patient's quality of life. So I can tell Mr. Johnson, hey, Mr. Johnson, your lung function improved by 150 mLs. And guess what? You're going to feel better and you're going to be able to do more. And furthermore, had been shown to decrease exacerbations. So controllers has become the mainstay therapy for the treatment of COPD due to all these effects that it has. And we can call it today that controllers change the natural history of the disease, change the progression of the disease.
Yeah, so thank you. That's a great point. So you've kind of seen the history, you've kind of seen how we've moved from the short-acting agents to the long-acting agents and how much better, seen all these studies that show how much better patients do and have improvements in lung function and reduced exacerbations. Why do you think we still have this issue? Like, what are some of the barriers to getting controller medications versus the short-acting agents?
I think they're very different issues. One is a lot of patients is the lack of diagnosis. So they're a little short of breath. They're not sure what's going on. They haven't had a diagnosis made. They haven't had a spirometry. That is the only way we can make a diagnosis of COPD in 2025. And then some prescribers will provide them the medication. And there is some SAVAs available over the counter. So that's an important issue, have to take into consideration that the patient may feel short of breath and go to the pharmacy and say, oh, this inhaler that you can take, that is a SAVA. And they take that, and the more that they take those medications, one, they are not impacting the disease. So the disease will continue to progress. And I had patients say, well, I've been using salbutamol for the last 5 years and still more short of breath. And I would tell them, listen, I'm sorry to tell you that, but salbutamol and the short-acting bronchodilators doesn't do anything for the disease. It's like you having a hole in your tire and you're going from gas station to put in air. You're not solving the problem, and that tire eventually is going to completely give up. So the also the short-acting bronchodilators, if you use it regular several times a day, individuals who are in their 60s, their 70s, they have other concomitant conditions like having cardiovascular disease, increases the risk of having cardiac arrhythmias. And I have seen patients that have these intractable atrial fibrillations that they're going to all these interventions. And what happened is these individuals take 2, 3 puffs or 1 or 2 nebulized as short-acting bronchodilators several times a day. So those induce cardiac arrhythmias. So there is not a treatment for the disease, and is significantly associated with increased morbidity.
That's a great point. And I think we're learning more and more about the cardiovascular complications in COPD, especially that, that inflammatory response you can see after an exacerbation. You'll see like shortly after that patients have an increased risk for cardiovascular complications. So I guess
Yeah,
really highlights how important, yeah.
Yeah, there are several in the last 5 years prospective studies and observations that highlight that when our patient has an exacerbation, the risk is not to having problems related to the lungs, is the possibility to having a cardiac event. If you think about that, the lung is the perfect organ for translocation. All the blood flow goes through the lungs every 3 minutes. So what happened in the lung doesn't stay in the lungs. It's not like in Vegas, it stays in Vegas. It goes all over the body. And you have on top of that, you have hyperinflation, you have hypoxemia during the exacerbation. So it is a perfect storm. If you happen to have an unsteady coronary plaque kind of hanging up there, this is the time that plaque is going to be loose, and this is the time the person is going to have a problem. So that's why back when the original gold document was published, in 2000, one of the objectives of treatment of COPD was let's prevent exacerbations. People say, these guys are crazy. So we're going to prevent those events with bronchodilators. But what we have found in the last 20 years is that the long-acting bronchodilators, and that's the reason they're called controllers, they do prevent exacerbations, and they have reduced the exacerbation rates that they used to be 2, 3 a year to less than 1 a year. And once we were able to combine those medications and start giving it in single inhalers, we were able to further enhance their efficacy.
Mm-hmm. Yeah, no, I totally agree. And I think we're all trying to really highlight a lot of the recent research that describes COPD as a systemic disease, right? Like you can affect,
Right.
they'll start with the lungs, but it can affect so many other organs. And that's so why it's so important to keep the lungs under control the best that we can. So I think that's a great aspect to highlight about the importance of the controller medications. So I guess kind of going back, you mentioned that part of the reason that we have the short acting overuse is because we kind of lack diagnosis of COPD. They haven't gotten their spirometry yet. Do you think there's other aspects to it that maybe there's this feel like patients maybe notice a short acting agent more or things like that?
What happens if you are much lower and you get something that will improve you for 10, 15% of your lung function? You will feel that, but this lower will continue to get lower and lower and lower and lower. So you're going down the steps, the stairs. That's where you're going. Every time you go, you start from a lower point, and the lower point it will bring you up a little bit lower point. What you want to do is you want to hold that. You want to bring them up and keep it over there. And that's what patients, once they start using the long acting, they don't feel that the medication work. And if you combine those, they will feel less because their lung function is much higher. They have this acute response. Having said that, some of the long-active beta-2 agonists, especially for Morero, it has a very quick onset of action, and there are studies that have shown that even given in combination with other medications on a steady state, the patient feels that medication, and some of those are like twice a day. So when they use the medication in the evening, they feel, oh, I'm not feeling this good. I'm a little short-winded. They take the medication, it brings them back up. So they feel some the efficacy. But I think the important question that you asked was, why still a lot of these patients being used, and especially the nebulized. And it has to be with reimbursement and has to be with Medicare. So Medicare give these patients, these patients, these medications, bags of these medications that, and it's very difficult to stop it. I had patients who tell me, listen, could you send another prescription canceling this because I have my closet full of these medications and I have not needed to use it because I don't need it. I'm taking my long-acting inhalers, I'm taking my controllers, so I don't need this anymore. So I think it has to do with reimbursement and the other medication, the long-acting bronchodilators. In some of the situations, the patient will have to have for payments. And that's a very difficult situation for some patients. I have to look at them in the eye and tell them, listen, I know you're getting these medications almost for nothing, but the reason you're getting is because it doesn't work. So you want to stay with that? I mean, it's fine with me, but you will be back in 2 years, more short of breath. You will have more exacerbations, more limited, and I may not be able to bring you back because these medications work to a certain extent. Will stop the progression, but I don't know how much I'm going to be able to bring you back. No, there is a financial compromise at this point, but let's try to work out and find ways to help you to get the medications. So many of the companies have assistance programs. When they hit the donut hole in Medicare, on their Medicare Part D, I tell them, okay, let's look at your medication. So a cholesterol medication, you can stop it for a month. I mean, it isn't going to kill you. You stop your cholesterol medication for a month, the cholesterol is not going to shut up the roof. A lot of patients stay like in Plavix after they had some intervention 3 years ago. I said, well, probably can stop for a month this. And if we start looking at what medication they need, we find ways to be able to help to get the inhaler medications. I rely on samples. I run away in my clinics everywhere, kind of getting samples. So try to find ways to bridge them so, they can get these medications back in line with the insurance. But in some cases, it's a financial constraint that we have to work around to give them the best interventions.
This podcast is sponsored by Viatris and highlighting the importance of controller medications in COPD. Viatris is a global healthcare company with a mission to empower people worldwide to live healthier at every stage of life. We provide access at scale, currently supplying high-quality medicines to approximately 1 billion patients around the world annually and touching all of life's moments. With our exceptionally extensive and diverse portfolio of medicines, a one-of-a-kind global supply chain designed to reach more people when and where they need them, and the scientific expertise to address some of the world's most enduring health challenges, access takes on deep meaning at Viatris. Theravance BioPharma aims to transform the treatment of specialty respiratory and neurologic diseases through the discovery, development, and commercialization of medicines that make a difference in patients' and caregivers' lives. Yeah, that's a great point. And I think it really highlights how important it is for us as clinicians to talk to patients, kind of really tease out how often they're using like their short acting agents, and maybe right, trying to tease out the overusers. But I've also there's other programs, right, that have involved maybe not just the clinician, but maybe our respiratory therapists, our pharmacists. So have you kind of dealt with any of those types of programs?
So the overuse of SABAs are probably due for several reasons. One is for lack of diagnosis. Some individuals feel short of breath. Some SABAs are available at the counter, so they go and get it. Or they also get it from their providers. I'm a little short of breath. I smoke. Well, let's see if this will help you. And patients receive short-acting bronchodilators. And they feel when they take the medication that their symptoms gets better. Unfortunately, gets better for 2-4 hours, but after that, they're going to be back where they were before. And this is doing nothing to stop the progression of the disease. The other overuse may have to do, especially in the Medicare patient population, is due to cost. This is very inexpensive medication. So patients under Medicare, they receive this nebulized and receiving huge amounts of nebulized. So patient gets confronted with the challenge that I get this medication for free, but at the same time, if I need to get a treatment to be effective like a controller, I would have to have a financial or copayments. And I can look at the patient in the eye and tell them, you get this medication for free because it doesn't work. It doesn't do anything for you and for your disease. What we need to do is we need to stop this disease progression. We need to improve your lung function. We need to improve your quality of life and decrease your risk of exacerbations. And a lot of my patients, they understand that. And then we try to find ways to then get them to get access of the medication. So I think it's a combination to answer your question of lack of diagnosis. These patients don't have a diagnosis of COPD, but they are short of breath. So they must have a spirometry to confirm the diagnosis. And second is for economical reasons and access that these short-acting bronchodilators are very inexpensive. So Medicare patients, they get it in huge amounts, but they don't work. So we need to develop ways to have access to the right medications to our patients.
Oh, that's a great point. And I actually we just had a really amazing article come out in the New England Journal about how we have these patients with symptoms and they actually had some kind of asthma or COPD and they weren't being diagnosed, right? They didn't have spirometry and how having that. So I think in kind of a natural environment, maybe they're just getting an inhaler and they're just getting symptomatic relief without that diagnosis. So I think that's a great point. So, and highlights how important it is for us to do spirometry routinely on our patients and get a diagnosis.
We need to get a diagnosis, and that's the big challenge. Let me tell you, for the last 25 years, we've been looking at other ways to make a diagnosis, and nothing has worked. At the end of the day, we go back to spirometry, we go back to a fixed ratio, be less than 70%. So that's going to be the fastest and the much easier way to make a diagnosis. In the future, with AI, we're going to see a lot of image is going to be the next frontier for the diagnosis of COPD. Through AI, there are algorithms being developed, have to assess the airways, have to assess the amount of emphysema, air trapping. There is a lot of new data about mucus plugs and how mucus plugs can have a poor outcome on patients. And probably the new interventions like biologicals, some of the efficacy may be related to the reduction of these mucus plugs. So, and that's where the patients experience the improvements in lung function and feels better. So they are in the near horizon. There is opportunities through AI and imaging, but today we still rely on spirometry.
Yeah, I totally agree about the AI. It's so exciting. I think also we're thinking that maybe you could diagnose some of the comorbidities of COPD with all this imaging that we have, like osteoporosis or muscle loss, sarcopenia. So, but yes, we're still at this, we still have to, our patients still need to get their spirometry. That's the where we are right now.
In the Gold Committee, we have stated since a couple of years ago that we strongly recommend that all COPD patients should get a CT chest. And for reasons that you mentioned, to look at other conditions like osteoporosis. But, for example, it's very common to see in these patients significant calcification in their coronaries. And there is a recent publication that showed that 70% of the patients who had these calcifications in the coronaries, only 20% has been diagnosed or has been risk assessed. So this gives us the opportunity when we look into that and say, this doesn't look good. We need to talk to our cardiologist. We need to do a stress test. We need to risk assess that patient. We need to look at their cholesterol, all the risk for cardiovascular conditions. But we would like to intervene before something bad happens.
Right, exactly. And it kind of goes back to how we were talking about COPD as a systemic disease that so again, really exciting future areas, but we still need to get our spirometry right now.
Got it.
So
Yes, ma'am.
And I think there's also a lot of interesting research going on with smart inhalers. Have you kind of encountered those where they kind of give you information on how well you're doing?
There is a delivery device that was approved several years ago. Uh, Very, very interesting. The challenges had not taken off, and it's for several reasons. So basically, this device connects to an application and will remind the patient, hey, it's time to you to take your controller medication, to take your long-acting bronchodilators. Oh, hey, you are taking too much of albuterol. You should not be using that much of albuterol. So the application will interact with the patient. This smart delivery devices also will give a patient immediate feedback while they use the medication, if their inspiratory flow was correct and the medication was able to enter the lung. The challenge has been all this data that is collected by the device. How can that data be transferred to the provider? Because you as a healthcare provider, you don't want to be wanted to receive every 5 minutes from every patient. Say, Mr. Johnson used two pulse of the albuterol. Hey, Miss Williams did this, did that. And what's the liability was associated with that? So the information is there, and the companies are working with algorithms how to streamline. I was a couple 2 weeks ago at the European Respiratory Society meeting. There were some of those devices presented there, and they presented some softwares to be able to streamline the information to the provider and develop some alert systems, both for the patient as well to the provider. So, for example, to tell the patient, hey, you have used too much albuterol in the last 24 hours. You probably may have an exacerbation, something wrong. You need to look for help. Uh, Alert the provider, your patient has been using too much rescue. We're instructed to look for help. So try to get it both ways. So that has been the main challenge, but I can see that this is only the beginning. With AI and all these technologies ready available, we're going to see in the near future more and more these smart devices available.
Yeah, that's a great point. Like maybe we can harness AI to maybe reduce some of the information, right? Like there's so much information that's coming from these inhalers. Maybe it can give us like a scorecard or something like that when we come see our patients in clinic instead of this. It's just so much information, right? That these devices are giving.
Is, for
Yeah,
example, when you get the reading of the CPAP on a patient, you get
right,
every single night for the last month. You
right.
get all these numbers, all this, and what I do is, I have to confess, I cheat because I go and look at the graph. The graph looks at the same level. That means that the patients did well, use it every day, but there are pages and pages. So all that has to become in a manageable way, has to be accessible to the provider, and more important, to identify potential risk of any problem in advance.
Right. You need something practical. That's a good point. Yeah. So that's no, I think that we kind of discussed a lot of aspects of controller medications and how important they are. I think, do you have any other thoughts on how we can kind of help as clinicians to make sure our patients are on the right medications, kind of where things are going in the future?
Think we need to start with the principle that what this medication did show us is that COPD is a treatable disease. What has happened in the lungs can be reverted, and a lot of those can be improved. As a consequence of that, all the healthcare systems are reported significant decrease in mortality in COPD. So, matter of fact, in the US used to be the third leading cause of death. Now is the fifth or sixth leading cause of death. It depends if you see the 24 or the 23 or 24 statistics. So we have impacted. So it's a treatable disease, but it's treatable if the patient is on the right medications. And the treatment of this condition are the use of long-acting bronchodilators, the controller medications. Now, the future is very exciting because there is not only all these medications. Okay, we had the bronchodilators, we can hit the ceiling, there is no more. But now we're having biologicals coming to COPD. We have two
Mm-hmm.
biologicals that had recently been approved by the FDA, has can further shown that you can increase more lung function. We thought we had reached the ceiling with the inhalers. Guess what? You can get another 15 mL out of that. And they are
Mm-hmm.
impacting the inflammation within the airway. So it's very exciting to understand that maybe other pathways, other mechanisms. We also recently have a new class of medications approved by the FDA, the phosphodiesterase 3 and 4 antagonist medications. And these medications is a bronchodilator and anti-inflammatory, is a very good mucolytic also. So there's completely different pathways of action. So the future for our patients couldn't be more exciting, but we have cures. But at the end, we need to start with prevention. We need to emphasize smoking cessation. And the tragedy that we live in today is electronic cigarettes everywhere, all these kids using it. You know, Amy, I would tell you something really, really horrible. I was in a plane, 32,000 feet, flying from Charlotte to Phoenix, and a gentleman sitting in front of me in the seat got his electronic cigarette and he puffed there in the middle of the flight on the
Oh,
plane. So that
wow.
addiction to nicotine that he had
Yeah.
is horrible. They just can't, he cannot do it. I mean, now, you know, all this being substituted with these pods that they put in their mouth. You see all these people putting stuff that releasing nicotine. So the challenges for the future still are very big, but we need to emphasize the need to prevention, the need to stop all this. But we don't want to be confronted in 20 years with another huge epidemic of nicotine addiction with severe cardiovascular and pulmonary diseases.
Oh, exactly. I love these two. You kind of made these two really amazing points, which is we have all these new therapies for COPD. So oftentimes I think I'll see a patient in clinic and maybe they're like, well, I don't think there's anything else, there's anything more we can do. And, there's nothing really that we can try. And I've never felt like I've never had a patient where I felt that way. I felt like there's usually something new and we haven't tried, or we haven't changed a therapy, or we have all these new amazing drugs and medications coming out, particularly biologics. And like you mentioned, the new phosphodiesterase 3/4. So I completely agree. It's a very exciting time. But you're right. We have these new barriers. We have these things that just the practical aspects like smoking cessation and e-cigarettes that we really have to work on as well. I think that's a great point. So I think again, it's just wonderful to talk with you about COPD. I think we're in such an exciting age, and again, we just love to have you on the podcast. So thank you again, Dr. Anzueto, for being here.
Thank you very much, Amy. Thank you very much for ATS for inviting me, and I'm looking forward to participate in the future.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.